Hello everyone and welcome to my presentation titled Predictors of Functional Mobility in Adults with Lower Limb Amputation, a Prognostic Systematic Review. My name is Marjan Saeedi and I am a PhD candidate at the University of Western Ontario. I would like to express my sincere gratitude to my supervisor Dr. Joy McDermott and to Dr. Tara, Dr. Mike and Dr. Paul for their valuable advice and guidance throughout this research. I also wish to acknowledge Javad Raisi for his kind support. I also declare that there is no conflict of interest. Today, considering my research, I will present the introduction, the method, the results, then the discussion, and finally the limitations and the conclusion. Each year, there are 180,000 lower limb amputation, or what I am going to say now on LLAs, happen in the United States, with numbers expected to reach 3.6 million by 2050. In Canada, LLA cases have also been increasing, particularly due to diabetes-related complications. These amputations significantly impact individuals' mobility, which affects their quality of life, independence, and ability to engage socially. Given this impact and importance, mobility becomes a critical focus in rehabilitation for individuals with LLA. While there have been many studies examining factors that influence mobility, there is a lack of a comprehensive synthesis of these prognostic factors. That is what motivated me to conduct this review, where I systematically assess these factors to better understand their role in mobility outcomes, or as it is stated, the objective. This study aims to systematically review and evaluate prognostic factors for functional mobility in adults with LLA. For a systematic review, I followed PRISMA-P guidelines and registered the protocol on Prospero. The literature search was conducted across major databases like PubMed, Embase, CINAHL, and Cochrane, supplemented by Gray literature searches and hand searching of the included studies. I used the Picot model to develop my search strategy, identifying terms and keywords relevant to lower limb amputation and mobility. For a selection process, two reviewers independently screen and assess studies for eligibility using Covidence for data management, and the disagreements were resolved with a third reviewer. For eligibility criteria, the studies focusing on predictors affecting the mobility of adults with LLA were included, and all the studies not examining the mobility, as well as the studies without a clear reference standard, review article, book chapter, case reports, and conference papers were excluded. Afterward, data extraction was guided by the CHARMS PF checklist, which helped ensure a consistent and complete extraction of study characteristics and prognostic factors. For risk of bias, we applied the QUIPS tool, focusing on 6 domains, including study participation and statistical analysis. Due to the high variability among the included studies, a narrative synthesis was conducted. This approach of the best evidence synthesis allowed me to evaluate the strength of evidence for each prognostic factor, categorized as strong, moderate, limited, or inconclusive. After conducting the result in the databases, in total 1,395 studies identified, of which only 14 met the inclusion criteria. These studies varied in design, including cohort studies like prospective and retrospective and cross-sectional studies, and these studies collectively covered 3,964 participants. The amputation level in the included studies was categorized either as an above knee or below knee. Regarding outcome measures, mobility in the included studies was assessed using both performance-based tests like the Time Up and Go and patient-reported outcomes such as the PLUS-M. These diverse measures allowed for a more comprehensive assessment of mobility, though they contributed to variability at the end. The results of the risk of bias assessments showed that the included studies are varied in their risk of bias, which from the 6 domains of the QIPs, the 2 domains of prognostic factors and outcome measurement had mostly low risk of bias, while the study attrition and confounding had moderate risk of bias due to the inadequate handling of missing data and not incorporating the confounding. The review identified 21 prognostic factors in general, which were categorized into 4 domains: sociodemographic, medical, physical function, and psychological factors. The sociodemographic factors which were recognized are age, sex, race, ethnicity, income status, employment status, BMI. The medical factors are comorbidity, etiology, level of amputation, rehabilitation type, stump length. The physical function factors are balance, hip range of motion, K level, prosthesis use, activity level. And the psychological factors are cognitive concerns and mental health. All of these factors, the purple highlighted ones, are the important ones which I want to discuss shortly. In assessing the strength of evidence for each prognostic factor, I applied a best evidence synthesis approach, which considers not only the consistency of findings, but also the quality and quantity of the studies reporting each factor. Strong evidence was found for factors like age, sex, comorbidities, level of amputation, mental health, and cognitive concerns. These factors were reported consistently across multiple high-quality studies, indicating support for their influence on mobility. For moderate evidence, years since amputation stood out. While results for this factor were also consistent, the limited number of studies and some methodological shortcomings reduced the overall confidence in this evidence level. Although findings suggest that time since amputation influences mobility adaptation, more research is needed with stronger study designs. Limited evidence was noted for factors like etiology, race, ethnicity, income, prosthesis use, balance, working status, activity level, and active dieting. Here, the evidence was consistent across studies, but the quality of the studies was lower, and only a few studies examined these factors. This limited the strength of conclusions we can draw, even though results pointed in similar directions. Finally, factors such as BMI, stump length, K-level, rehabilitation type, hip range of motion, and FIM score or functional independence measure were classified as having inconclusive evidence. These factors were reported in only one low-quality study, making it difficult to make definitive statements on their impact on mobility. This review has a few key limitations. Due to high variability in outcome measures, a meta-analysis was not feasible because different constructs were assessed, ranging from gait speed to self-reported mobility, which made statistical pooling challenging. Also, other kinds of variability were seen. Grouping issues also affected consistency. For example, studies often combine different amputation levels like ankle and transtibial, which could affect mobility differently. Most studies had a short-term focus, lacking long-term follow-up to capture how mobility changes over time. Prosthetic factors like fit and comfort, crucial for mobility, were rarely explored in depth. Additionally, there was no research on the contralateral limb, which is vital for balance and overall mobility. Finally, limited evidence exists for factors like race, income, and balance due to a lack of high-quality studies. Future research should focus on these areas, ensuring more consistent grouping, long-term follow-up, and a deeper look at overlooked aspects like prosthetic fit and contralateral limb strength. And finally, in conclusion, this review identifies key predictors of mobility in adults with LLA, including age, sex, comorbidities, cognitive concerns, and mental health. Tailoring rehabilitation programs to address these factors could optimize mobility outcomes, enhance quality of life, and promote independence for individuals with lower limb amputation. Thank you very much for your attention. If you have any questions or would like to discuss this topic further, please feel free to reach out. I would be happy to connect.